Technician from Kerala, Dr. Ananda Keshavan is the Vice President of Central IAP right now, and the Chairperson also for the day. My great faculties here, esteemed faculties, Dr. Raju, Shah, as well as Dr. Yachha, sir. My seniors from the IAP fraternity across the country, I can see quite a good number. Dr. Arindra Singh is also there. He was the first executive board member, as well as a lot many seniors are Dr. Tandon and lot many seniors are around, and Dr. Taneja, and my great friends from IAP Kerala, and my friends who have logged in for the day. Good evening and greetings again from the Doyen series. We are quite fortunate to have, despite the COVID challenges and all of the hiccups coming up from the professional side, we are quite fortunate to have the academics running in full steam on the DAP front as well as from the branches. And of course, it's a great learning experience having the tips of practice from the seniors who have done it for maybe have been through this maybe 20, 30 years. No textbook can replace or comment or can make up for this. And I'm sure every topic and every session from our doyens is real, at least something which can make your life comfortable in the clinic and practice and the hospital setting the day ahead. So I'm sure we have got a great time here today, and I'm privileged to introduce my faculty for the day through the PowerPoints. Our chairperson for the day is our beloved friend and Vice President of Central IAP, Dr. Ananda Keshavan. And Dr. Anand needs no introduction to any IAP forum. He is the additional professor of pediatrics in Government Medical College Thrissur and was past national president of IAP Neurology Chapter. Apart from that, he has got the editor-in-chief of Indian Journal of Emergency Pediatrics and chief editor of the textbook of radiology. And he has got many publications in national and international journals to his credit. And as has been noted at the outset, Dr. Anand has written a chapter on iron deficiency, and when I sought his help for this chairperson, he was quite happy that I say, Ramesh, I'm so happy to be learn further about iron deficiency, and we'll have a good interaction. And of course, Raju Bhai is there so that we can make up the entire session very interactive. So I welcome Dr. Ananda Keshavan formally on behalf of Doyens as the chairperson for the day. We have Dr. Raju Shah, and as fondly remembered by everybody as Raju Bhai, as Dr. Narayan has put it, he is known as in IAP circles as Raju Bhai only. And he is one person who was instrumental in taking up IAP to different heights. Maybe he has showed is a versatile genius who has shown his profile in every aspect of Indian Academy of Pediatrics, academics, organizational, as well as advocacy and every front. Is the former professor and head at the Department of Pediatrics, GCS Medical College, Ahmedabad, and he has been the president in 2005. That is something which keeps him apart, but apart from that, he was the president of the SARC Pediatric Association, chairman of the ACVAP Committee on Immunization, chairman Infectious Disease Chapter, IAP ICMR Committee for Action Against Antibiotic Resistance. Everywhere he has got his stamp. And currently he is the medical director at Angur Institute of Child Health, Ahmedabad, a well-run clinic. I had been there twice, and Raju Bhai was very courteous to be there as a host for me there. He is got a lot of awards and publications to his credit. He has received FRCPCH, Dr. Shantila Shetoration, as well as the examiner for MRCPCH and executive editor of IAP Textbook of Pediatrics, and published more than 50 articles in journals. So we have got a great academician, a great organizer, great IAPN, and somebody who has got his stamp in various domains of pediatrics. Dr. Raju Bhai is here to deliver a lecture on iron deficiency, anemia, cognitive development. Welcome, Dr. Raju Shah, sir. Dr. Yachha, sir, is here, and anybody in pediatrics, especially those who have been through the gastroenterology domain, is going to go through such presentations and lectures. And I've been fortunate to listen to him many a time, especially in the ISPAN. He was the, as Eddie put his authority as the head of the department of founder director at SCP Sanjay Gandhi Postgraduate Institute in Lucknow. And he has turned out, his team has turned out a good number of gastroenterologists, TM gastroenterologists across the country who have got disseminating information and clinical excellence in different parts of the country right now. So he can be called a teacher of teachers, a right good and teacher of our master trainers in gastroenterology. Sir has got a Commonwealth Medical Fellow in Pediatric Hepatology and liver transplantation from King's College London, the very famous institute. He's head of the department as well as Pediatric Gastroenterology, Hepatology and liver transplant at Sakara Academics at Sakara World Hospital, Bangalore, right now after his retirement from SGPGI. And I believe it's quite not that easy to have an appointment for, or an opportunity from Dr. Yachha sir to have a session with in any forum. We are quite privileged to have his experiences shared with us in this on a topic which seems that not that clinically much difficult to diagnose, but very difficult to treat, I believe. And as Dr. President has put it, functional constipation is seeing is on the rise with the COVID challenge, the epidemic coming up, children being at home and other diseases keeping away. Constipation has come to the forefront. So Yachha sir is here to enlighten us more on functional constipation and the different aspects. So friends, we have got two doyens here for the session here today. And I'm sure our delegates and our friends on the platform will be quite privileged to hear from these two doyens. And please post your queries on the chat box. Dr. Anandakasavan and Dr. Ashraf will be handling the Q&A session after both the sessions are concluded. So it's my pleasure to invite Dr. Raju Shah sir for the first session of the night. Please welcome Dr. Raju Shah sir.
Thank you so much, Dr. Ramesh Kumar. Dr. Ashraf, Dr. Narayanan, Dr. Anand Keshavan, co-faculty and my close friend, Dr. Yachha, office bearers of the IAP Kerala branch and all other branches, and dear friends. It's first of all, let me thank the IAP Kerala branch, Dr. Ramesh Kumar, Dr. Narayanan, for inviting me to share my views on this very important topic. As they have already, told us about what I'm going to talk today. Well, friends, iron deficiency anemia is not a new name to pediatricians. Anybody joining as the first year resident will definitely start learning about the iron deficiency anemia because that's the commonest type of deficiency found in children and anemia. And that's why many a times, even in a child, when presented with so many different type of, presentation, child will have anemia and still we probably won't mention that as anemia. From our ancient literature, I could find that food we eat influences our memory, comprehension, thinking, judgment, intellect, and emotions. Though in the past we did not realize this, that how true this sentence is, and with more and more understanding about the different type of deficiencies, we have started understanding that how our food influences our lifelong behavior and what we can do in the life. So in spite of all the progress in medicine and science all over the world, still anemia continues to be a most prevalent disorder that we all know. And especially in pediatric setup, this is the commonest type of disease or a deficiency that we see. And though it is a very common, it is very less readily recognized, excepting when there is a severe anemia. Otherwise, most of the time, it is the other conditions which are recognized for which child is presented, but the mild to moderate anemias are not recognized and missed many a time. You all know that iron is a very important component of hemoglobin, and all over world, probably iron deficiency anemia is responsible almost for 50% of the anemia all over. And almost 25% of world's population is affected by anemia, of which 50% suffer again as a iron deficiency anemia. So around 800 million children and women worldwide suffers from the anemia, and 40% of children and 50% of women, it is caused by iron deficiency anemia as per the WHO report of 2015. And if you look at India, from the very nice article published in 2011, it is the most common and widely prevalent nutritional disorder and commonest manifestation of iron deficiency as anemia. Low-income developing countries, there is an increased risk for maternal and child mortality because of the iron deficiency anemia. So if you look at the overall population, where is the high requirement of iron, the risk population will be infants, children, adolescents, and pregnant women. So this is a known fact, and every one of us, being a pediatrician, knows this very well, and we always try to recognize this in all our group of children that we take care of. If you look at the data, WHO in 2001 found that 30% of the children aged between 6 months and 4 years, and 48% of the children aged 5 and 14 years are anemic in developing countries. In Asia, the prevalence of anemia in children was exceeding almost 90% in children less than 2 years. And our own NFHS 4 data of 2015-16 showed the prevalence of anemia among children less than 5 years of age to be around 59 to 60%. The prevalence among children under 3 years of age was close to 80%. So this is what the exact prevalence in India is also. And if you want to look at state-wise, though Kerala is not mentioned here, the Kerala probably has less anemia as compared to all other, but almost all the states, there is a continuous anemia in spite of all the interventions that is done. And there is hardly much difference between the 2005-6 and 2015-16 data. So in spite of 10 years, different type of schemes, nutritional schemes and iron and folic acid supplementation schemes, there are not much of improvement, almost similar data even after 10 years of all this effort. The clinical features are well known, but unfortunately what happens that if there is only iron deficiency, the symptoms are not seen. So only when the anemia develops, then only symptoms are seen. And initially, the symptoms are not that bad, and probably it's because of that they are not recognized. Only later, when there is a moderate to severe disease, then only the symptoms are seen, and that is why they are recognized. I don't need to, count these symptoms. They are all well known to all of you. So I'm not going into detail of those symptoms. So this is how we normally see anemia, pallor, and koilonychia. They are the important features. Now, why this age group, especially infants, they are developing iron deficiency? There are three important reasons. It could be because of increase in demands of a growth in a child, or decrease intake or absorption, or increase in losses. So all these three important groups, because of that, this develops. Sometimes there is a combination of both. There is a increase in demand in all these children, but along with that, there could be a decrease intake or decrease absorption of iron, or there could be a increased losses. So the combination of factors can lead to a development of iron deficiency to begin with, and then iron deficiency anemia. When iron deficiency takes place, or iron deficiency anemia takes place in the body, the consequences, most common things we know, but the other things that has now realized recently in last 10 years is there is a reduced physical and cognitive development in children. And in a developing countries, there is an increased child mortality. And when they reach to adult age, there is a reduced work productivity in adults. So just simple iron deficiency anemia at one age of a child doesn't end there. There is also an issue, and that probably the effect of iron deficiency anemia persists lifelong, and even it works there in the adults, and the productivity is also decreased over there. So what happens that, what are the effect that leads to all this type of the effect in the body? Mainly there is a iron deficiency acts on the cellular functions, and the cellular functions creates all these problems. We have realized that, and everybody knows this is a common function, that for tissue delivery of oxygen, hemoglobin is required, and hemoglobin is formed with iron and globin. And so it affects the tissue delivery if there is a deficiency. Not only that, there is an effect also on tissue proliferation and growth differentiation. Another important thing that we have realized that there is a compromised myelogenesis in the brain and CNS tissues. It also affects the immune function, and because of that, there is the immune deficiency partial, and it leads to a more common infections. It also acts on the energy metabolism and absorption, and that is why also there will be an effect there. And there is a biotransformation, and here also there is an effect of iron deficiency, and that leads to a different type of problems. So till now we were looking as iron deficiency only for the anemia, but now we have started looking beyond anemia, and that is iron deficiency itself can also create problems. Till now we realize that it is the effect when child develops anemia, but now we have realized that it is the iron deficiency itself that can create issues, and that is there will be an effect on various tissues, organs, and system. The most important is the impaired brain development and cognitive, behavioral, and psychomotor impairment. Not only that, there will be impaired cell-mediated immunity and bactericidal functions also. Over and above this, we have realized that many other symptoms that occur, or some of the diseases that can occur, are also because of the iron deficiency, and that includes febrile seizures, pica, breath-holding spells, restless leg syndrome, and thrombosis and acute CV syndromes that can also lead because of the iron deficiency anemia. So friends, iron deficiency doesn't just lead to anemia that we commonly infer or we realize, but there are many other things that can happen with iron deficiency. So there is a very important that we realize the iron deficiency or recognize the iron deficiency rather than recognizing only anemia. So at the earliest stage, if we recognize that or if we try to correct, that will go in a long way. So Sally Graham in Cognitive Development in Children has stated that there is a considerable evidence that anemia is associated with a large number of socioeconomic and biomedical disadvantages that can themselves affect children's development. And this development is just not physical only, but mental also. So what happens in a brain development? Why iron deficiency is so important? Why we are now worried about that? Because last 10 years, there are so many research that has brought out this important effect of iron deficiency, that it affects the brain and behavioral functions. In early life, it affects the 3 major neurobehavioral domains, which includes speed of processing in the brain, the effect or the feeling domain of a brain, and learning and memory part of the brain. So when deficits occur while the infants are iron deficient and persist despite iron repletion, this effect on all these 3 domains which persist for a long time, and even when you supplement the iron, there are some changes which are lifelong changes and they are not improving. So that is the effect of iron deficiency. The mechanisms of this effect are long-term alterations in dopamine metabolism, myelination, and hippocampal structure and function. So this is something new that has come, and that has really made us think that how we should manage or how do we prevent all these issues. So where does the iron deficiency act, or where the iron is required? In the first 32 weeks of gestation to 2 years, it's a critical period for myelin development. Myelin is nothing but a fatty coating on nerves that mediates speed of processing. And here, if the iron deficiency is there, there will be an effect, and myelin, there will be a defect in the myelination of the nerves. Another important area where the development or the effect occurs is the hippocampus. So the critical period for development of hippocampus is 28 weeks to 18 months. Because of the energy need that is there, there will be a complexity of brain structure, which in turn supports the learning and memory. So the effect on hippocampus ultimately leads to the defect in learning and memory. And third important area where it affects is the dopamine. So the most critical period for the dopamine to develop and effect on the brain development is the mid-gestation to 3 years of life. So dopamine helps in mediating rewards, affect memory and motivation, all the 3 areas. So the iron deficiency acts at all these 3 levels. And we know that, so before the delivery, during the pregnancy as well as antenatal time and postnatal time, both, especially the first 1000 days of life, they are very important. And during that phase, this iron deficiency is there that gives a very long lasting effect, and children are suffering because of that. To give this idea, there are so many concordant studies of short and long-term effects on all these 3 areas, that is myelin, energy, and dopamine and sleep. On human itself, there are more than 50 studies which have been done, and they are very clearly showing us that there is a slower speed of processing if there is iron deficiency. There is a reduced learning and memory when there is iron deficiency, as well as there are long-term effects. There is a hesitancy, weariness, poor social interaction, and there is a poorer motor coordination in those children who have iron deficiency as well as the long-term effect. So in all the areas, especially of cognitive development as well as the socio-motor development, there is an effect of iron deficiency, and it's not just only a temporary effect, it's a long-term effect, and that has been very nicely shown in all these studies. There is one important study that was published in the 2016, that they tried to look at the correlation of serum iron level and IQ scores. And here again, if you see that serum iron and IQ, as the serum iron levels are more, the IQ levels are also more. So that's also again telling us that the iron deficiency can lead to a reduction in the IQ scores or reduction in cognitive function. And so it's very, very important that we take care of iron deficiency as early as possible. Very good article published in Journal of Nutrition in 2001 that showed us that the longitudinal studies consistently indicate that children anemic in infancy continue to have poorer cognition, school achievement, and more behavioral problems into middle childhood and also in the adolescent. Some other papers have shown that the adolescent delinquent behavior is also related to the iron deficiency anemia. There are case-controlled neurophysiological studies also. They have found there are differences in iron deficiency, like speed of neural transmission in the auditory system, rapid eye movement, density in active sleep, and recognition memory with event-related potentials. All 3 were affected, and there were differences when the child was having iron deficiency. So again, telling us that it's very important for the neurophysiology also. There are also studies which have shown that there are some brain metabolic changes also seen if there is a iron deficiency, like metabolic changes in hippocampus, then metabolic markers are reduced. There is a loss in hippocampal area and frontal lobe of cortex in iron deficient children. The NMR spectroscopy changes are seen in hippocampus. There is an altered dendritic structure, altered synaptogenesis, and deficit in spatial learning in iron deficiency. So all those were established, and in this review article by Lesov, he has very clearly shown that how does this affect, and there is a long-term effect of it. There are also studies which have shown that there is a defect on myelination, as I talked in the first slide. There is a decrease in myelin lipids and protein, which is a long-lasting. There is a decrease in myelin content, so it remains permanent there. And there is a decrease in the number of oligodendrocytes in the adult brain, and that also remains permanent. So that not only there is a short-term effect, but there is a long-term effect of iron deficiency. So there are also effect on the neurotransmitter functions. Iron is very, very essential for tryptophan hydroxylate and tyrosine hydroxylate, which are important for the serotonin and norepinephrine and dopamine in the brain. There is also effect on the density of D2 and D1 receptors and dopamine transporters. And THY1 neuron surface protein was also decreased in the brains of iron deficiency rats. So certain animal studies as well as on the human brain studies have shown that there is also defect in the neurotransmitter functions when there is a iron deficiency anemia. There are studies they looked at what is the effect on emotion and attention regulation, and there also iron deficiency in children and infants. They found that they present behaviorally as listlessness, weariness, and fatigue. There is a poor emotion regulation, which is characterized by emotional volatility, mood lability, emotional intensity and reactivity, and disruptive and angry outbursts, and which persist in the adolescent age. And what nowadays we see, the children coming from low socioeconomic class, showing more of delinquency and very labile emotional intensity and reactivity. It may be because the result of those things that they are iron deficiency in the young age. The children who have difficulty regulating emotions are apt to act out aggressively and have problems delaying the gratification. So these all things can lead to so many behavioral adolescent problems, and that persists for a long, long time. There are studies which have shown that if the infants are having iron deficiency, and if you compare them, follow them up to 10 years and look at their recognition memory, they were deficient. So again, there is a long-term effect on the memory. Similarly, there are studies which have shown that there is an association among infant iron deficiency, childhood emotion, attention regulation, and adolescent problem behaviors, as I just talked just now. So findings elucidate how poor childhood regulatory abilities associated with infant IDA, which compromises adjustments in the adolescent age. So of all these, one study which have shown that the persistence of problem behaviors derived from infant iron deficiency anemia highlights the need for primary prevention to reduce its prevalence and secondary prevention to lessen the long-term effects of these pervasive nutrient disorders. So very important that we recognize them and manage at the earliest possible, just at the stage when there is iron deficiency and not the anemia developing. So why as pediatricians we are worrying about iron and neurodevelopment? And we all know, as I had shown earlier also, that the three pediatric populations are very high risk for the iron deficiency. They are the fetus and newborn. So it's a antenatal period and neonatal period. Children 6 months to almost 2.5 years or 3 years. And then teenage girls and adolescent girls and reproductive age girls. Because all these show a wide range of motor and cognitive deficits while they are having iron deficiency. So unlike in adolescence, early life iron deficiency results in neurodevelopmental alterations, and that persists despite iron replacement or iron repletion. And that is why we are more worried, and we need to recognize at the earliest and start managing them. So now what can be done to recognize and prevent it? We all know that prevention is always better than cure. And so prevention is more important, and that is how we can take care of that population in the later life. This is a spiral that is always when we talk of nutrition and the reproductive cycle, that is important, because nutritional interventions during pregnancy and the first years of life have positive effects on human capital formation and may increase productivity, and therefore they may impact socioeconomic development. And so to build a better human capital for the country, it is better that we take care of the pregnant women and first the 2 years of life. And that is why nowadays even UNICEF is talking about first 1,000 days, which are very important for nutrition interventions, and that helps. And even there are studies, and they have in 2014 they had held one conference in which had shown that to build a better brains, it is better to have a good nutrition in the first 1000 days. And it also included iron in that good nutrition or for the intervention that needs to be done in first 1000 days. So the management or treatment again will, as there are multiple factors involved for the iron deficiency anemia. So eradication of underlying cause will be very important. So if there is a deficiency or if there is a loss, so we have to take care of diet. So there is enough iron coming in the diet. We have to take care of if there are worms and they are losing blood, then antibiotic treatment. And if there is any issue of chronic bleeding, we have to find out the cause and treat accordingly. We need to correct anemia also along with that and correct the iron deficiency at the earliest. And for that, we can't just only rely on diet. So immediately we have to start the iron therapy, which can be in most of the situations, it is the oral iron which helps and you don't need parenteral, but in some situation, especially when there is a severe anemia in pregnancy or there is a severe anemia in adolescent or a young child between 5 to 10 years, you can go for parenteral therapy also. And very, very severe anemia in critical situation, we need to give blood transfusion also. And in a follow-up, again, we have to see that children continue taking well-balanced diet so they in future they do not go for iron deficiency anemia. So how do we supplement iron? For that, we have to understand the what are the requirement of iron. And so the level of iron store for the child at the time of birth, which in turn will depend on the iron status of the mother during pregnancy. And so that is why we should know what is the iron store of the child at birth. So whether the child born is of low birth weight or normal birth weight. If the child is low birth weight or child is premature, then there is no transfer of iron, placental transfer, and that is why child will be having a very low store. So we have to understand that. Whether the child is breastfeeding exclusively or with other foods, and if other foods, then whether they contain iron absorption inhibitors or iron absorption promoters. That's also important because that helps us in the planning, the management. And the quality of food consumed and whether the availability of iron from its, whether it is poor or good. So that also tells us that how should we plan out, because it's not just a short-term planning. It has to be a long-term planning so as the iron deficiency is corrected and further deficiency is prevented so as they do not develop the issues in the future. So in almost all the cases of iron deficiency, it is the oral iron supplements which represents the mainstay of iron deficiency treatment. And it's very easy, cheap, and effective in most mild to moderate cases. So it can be treated by just simple ferrous sulfate salt. And we all know that the anemia is corrected very fast. Within 15 days, there will be a good correction of 1 to 2 gram if we really give a full dose of iron. So there are studies which have shown that the iron deficiency can be treated or prevented by iron and folic acid during the pregnancy, and there are interventions which are done during the pregnancy. So that has really helped, and in our country also, the supplement of iron and folic acid during pregnancy has helped, and we have seen that in the national surveys that when these mothers took the iron and folic acid, there is a good extra iron in utero and better cognitive function in the childhood. So it's a very important, and we need to continue it. Not only continue, but we need to expand the span of that so as all the before conception and during conception and pregnancy, the mother gets this iron and folic acid. So now, when the mother delivers a child, what is the iron store in the newborn? There are studies which have shown that in a newborn at birth, the iron store is around 75 milligram per kg. But it will depend upon what was the hemoglobin concentration at birth of a child and what was the hemoglobin of a mother, both. And we all know that this iron store gradually starts depleting, and especially in a low birth weight child, by 3 months, there is almost coming to very, very low level or almost completely depleted. In a term child also, there is a depletion by age almost 5 to 6 months. And if the premature child is there, then the depletion is much earlier because there is a very little iron store in these children. There are studies which have shown that if we go for a delayed cord clamping, that is we clamp the cord after about 2 minutes, then it leads to higher ferritin and iron stores at 6 months of age, and probably these children has good store up to almost 8 to 9 months of age till they start taking good oral supplementary food. So that's very important, and that is why there is a recommendation that if the there are no other issues, probably it would be better that we clamp the cord by almost 2 minutes rather than immediate clamping the cords. So these children, as you know, they all have a depletion of the iron store. There are recommendations that we need to give supplementary iron, and how much needs to be given. So in our exclusive breastfeed term infants, those who are born size appropriate for their gestational age, they need almost 1 milligram per kg per day, almost starting at 4 to 6 months of age. And if possible, preferably from complementary foods rather than as a supplement, as a iron therapy. But in some situations, and especially children coming from a lower socioeconomic class, they may not get enough iron as a complementary food. So in that case, you can give iron supplement also. But the maximum supplement that we give at that age is 15 milligram, even if the child is 4, 5, 6 kg weight. So that is what we normally recommend in a breastfed term infants. If the child is a premature born and low birth weight, children need supplements at early age, and their supplement need will be a little high, that is 2 milligram per kg once per day. And it should be started earlier at 1 month, and it should continue up to 12 months of age. And maximum iron that we normally, highest amount is the 15 milligram and not more than that. Then children becoming little older at the age between 1 to 3 years, they require almost diet as a RDA, 7 milligram per day of iron. Children between 4 to 8 years age, they require 10 milligram per day of iron, and children between 9 to 13 years old, 8 milligram per day. So it is very easy to manage through their food habits or the food that they are taking. They should get this iron from their food so as they do not develop the iron deficiency. So requirement is not that high, and it can be easily managed if we give them proper counseling and train the mother to give this type of food so as they require. Sometimes in children 9 to 13 years or adolescent age, they start going out and eating the junk food and other foods that may not give them the enough iron. And in those situations, recognizing the iron deficiency, we might need to give iron supplement. And there are WHO has given some guidelines that certain types of target groups where there is a very high possibility of those developing iron deficiency anemia, they should be given supplement of iron as a iron therapy, at least for a consecutive 3 months in a year, in the range of 10 to 12.5 milligram of elemental iron. So the target groups can be infants and young children, where you give 10 to 12.5 milligram. Preschool age children, you give 30 milligram elemental iron per day. And school age children, that is 5 to 12 years of age, 30 to 60 milligram of elemental iron. So if you give for 3 consecutive months, they get almost, because that will be stored in the body, and so they have enough iron, and rest of the iron they can get from their food, and so they will not develop the iron deficiency, and they can have a good growth and development and brain development also. Our national guideline for prevention and control of iron deficiency anemia in infants, they also recommend use of iron and folic acid supplementation for the prevention and control of anemia across India in pregnant women infants, young children, and adolescents. And there are, different programs going on, and especially for the pregnant women as well as for the school children, they get this iron supplement from the school or from the Anganwadi and other areas. That helps them, and that can definitely reduce the iron deficiency. So to summarize my talk, the iron deficiency is the most common nutritional deficiency worldwide and an important public health problem, especially in developing countries. There is convincing evidence linking anemia, especially iron deficiency anemia, with adverse maternal and birth outcomes with developmental consequences. These consequences have significant costs associated with long-term adverse outcomes and economic penalties also, especially among the poor and disadvantaged socioeconomic class people. Iron plays a critical role in early neurodevelopmental neurodevelopment that has been seen by different studies. Multi-layer investigations demonstrate that the cognitive and behavioral deficits are due specifically to the lack of iron. The pathways to adverse outcomes can be multiple through pathways such as small gestational age births, adverse impact on cognitive development, work capacity, and long-term consequences. And we have potential solutions and emerging evidence indicating that though iron folate are important, but multiple micronutrient supplementation in pregnancy may be better than isolated iron folate administration alone. But at least iron folate should be given to the pregnant women especially, and then also supplement in the school programs, school health programs, and adolescent health programs. Thank you, friends. If there are any questions, it will be my pleasure to answer them.
Thank you, Dr. Raju Shah, sir, for that excellent illustration on iron deficiency anemia, one of the commonest problem, especially emphasizing the non-hematological manifestations. And I request you, please remain with us till next session. We will handle the chat box after the Yachha sir talk. There are a lot of questions in the chat box. And now I invite Dr. Surendra K. Yachha sir for delivering his talk, one of the commonest problem in children, that is functional constipation, management of functional constipation in children. Surendra sir, over to you.
Yes, sir. Dear fellow pediatricians across Kerala and Calicut, respected chairpersons, moderators of the session, Dr. Ashraf, Dr. Ramesh, Dr. Ananda, Dr. Narayana, and one of my most respected and dear friend, Dr. Raju C. Shah. I worked in PGI Chandigarh from 1983 to 91 when I was an MD resident of pediatrics, followed by DM in gastroenterology, which I followed a very difficult decision on those days, and followed by faculty at Chandigarh. And thereafter, I moved to what's called Lucknow, where I was sought to develop pediatric gastroenterology as a subspecialty in Department of Gastroenterology. So I developed this department from the scratch, from one bed onwards to one of the best departments right now in the country, which has got the largest infrastructure, labs, faculty, and the training programs. And that is that's why in Uttar Pradesh, we could shed some light along with adjoining states of that state and also in the rest of the country. And thereafter, I moved to Sakra last year in the month of April 2019 and started there the pediatric super specialties. You can see here, this was the creation of a new super specialty area for pediatrics, which was not earlier there at Sakra World Hospital, Bangalore. And thereafter, the facilities were created, which were state of the art. And most of the children who stood in the examination on the merit category were awarded on that particular day by dignitaries of this This is the endoscopy facility for infants and children, which I had understanding with that hospital because this is a Japanese government hospital totally. And they were ready to develop all these facilities for infants and children. Now is the question of management of functional constipation. Eating but not passing out. Agony and distress for any person, whether it's a child or an adult. More so in the West and less as compared to the West we find in our country. What is the definition? Chronic constipation more than 4 weeks duration. And this is a criteria which has been given by Rome. Rome is a place in USA and is a very, very respected and honored in the GI luminal disorders. Frequency less than 3 per week, more than 1 episode of fecal incontinence. That means incontinence means when there's a leakage of the stool in the underwear per week, there's a leakage occurring. Painful defecation, large stool in the rectum, large stool obstructing the toilet. So 2 of these parameters if present would mean constipation. It does not mean only infrequent passage of the stool. So therefore my fellow pediatricians should ask also about this incontinence, any painful defecation, large stool, they may be features of constipation. See why I have deleted this part. I will discuss this part 3 per week. I'll discuss a little later based on the Indian data. Now this was a landmark study in 2010 we had conducted at our hospital. See, we had no data from India. We keep on copy, cut, paste, and follow the instructions which are given by the Western countries, which may not be appropriate for our country. Therefore, we did a study and we looked at the etiology, clinical spectrum of constipation in Indian children. And this was the first study wherein an editorial was invited from a London hospital by the journal. And this was appreciated study in the sense that this was the first one and many things were highlighted. Now in this, we had 137 cases from our own hospital and majority of them were functional constipation. Hirschsprung disease, which was commonly thought of as a common problem, was not that common. It was around 6 to 10% of the cases. Congenital anomalies, anorectal malformations, spinal cord abnormalities, disorders with mental retardation, spinal muscular atrophy were the causes, other organic causes. Therefore, any patient coming to you with constipation, you should look for these organic reasons, which are called red flags. You should look for malformation, examine the rectum, please. Look at the spinal cord, any disorders of the neurological disorders or atrophy or neurological weakness. Celiac disease was found because in the North India, celiac disease is quite common. In 2 of the patients, we had found celiac disease as a cause of constipation. But here, the lesson is that these are the patients. It is not that all patients of celiac disease should be, or constipation should be looked for celiac disease. No, it is only those who have growth failure and anemia associated with constipation, they may be looked at. Now, common mistakes in functional constipation. While at Bangalore, I have seen number of patients of constipation. What I observed earlier also and now also, that where is the problem actually? Why pediatricians are missing this problem in a bigger way, and they have to go, patient has to go from doctor to doctor. And forgetting to counsel properly is very important, which I will explain. Non-implementation of diet, quick withdrawal of primary drug, give this whatever laxatives you give, 3 weeks, 4 weeks, they forget to tell how long they have to give this. Multiple therapy for optimizing of the primary drug. So multiple things are being tried, weeks time, 2 weeks time, 3 weeks time. That is not going to make actually headway in this disorder. Now this is a recommendation guideline. So I thought that time I was the president of pediatric gastroenterology, and I thought that we should have a guideline on constipation, which we published in 2018 Indian Pediatrics. And this is a very, very good article. I think anybody who has to read constipation in children should go through this. It's very practical, given in tabular form. Most of the things, all the drugs are explained with dosages, everything in this issue. Now you see here, one basic thing which one has to understand about constipation. Here is actually external sphincter, you can see here. Internal sphincter is here. And then we have an angle which is created between the rectum and the anus. And this angle is obtuse. This is called the anorectal angle. There is a muscle here, the pelvic floor, that is actually constituted a levator ani muscle. But this muscle has got one more component inside, which is called the puborectalis muscle. It forms a ceiling around the rectum. Basic thing to understand. And whenever there is a defecation, the diaphragm contracts, the abdominal muscles contract, and the intrapelvic pressure increases, propagating the sequences in the colon and the small bowel. And what happens with that? With the increase in the pressure, pelvic floor relaxation takes place here. You can see in the diagram, puborectalis muscle relaxes. So what happens, this angle, which is obtuse, becomes much more obtuse. That means it straightens out. External anal and internal anal sphincters, they relax. And with the result, there is expulsion of the stool. This is a very important thing which one has to understand. There's a coordinated, simultaneous effort of many things, many muscles, which takes place during the process of defecation. Now, what is the pathophysiology? Toilet training, something happens. See, if you look at different books, journals, toilet training is not recommended less than 2 years of age. It should be above 2 years of age. And any fault in that training, whether the disruption because of the delayed defecation, painful defecation, frightening, there's a hurting a little now, there's a conscious decision of contracting and relaxing skeletal muscle. This goes wrong. The constipation develops. So there could be many other factors which are important, but this is one of the major factors which results in constipation in children. Now, what happens? Constipation, we all know that colon is the organ of water absorption, electrolyte absorption. As the stools pass from ascending colon down to the descending colon and rectum, the water absorption takes place more and more. And with the result, when we pass our stool, that is solid. So liquid stool, which is in the ileum, becomes solid stool as it reaches the rectum and we expel that. So what happens? When the stool gets held up in the rectum, there is further absorption of water from the colon. And it gets on accumulating in epileptin. With the result, there is a dilated rectum, which is called megacolon. Abnormal motor activity takes place. We are unable to generate pressure for a proportion of the stool because the dilated rectum does not perceive the way a normal rectum will perceive the pressure for passage of the stool. So there's also neuronal reflex. You will observe that those children who are having constipation will have less of appetite, will feel easily full when little you give to them. That's called satiety. Abdominal pain is always there, and distension of the abdomen may take place depending on how long and how prolonged is the constipation. This is a simple cycle to understand what happens in the constipation. The counseling, therefore, when this is a normal rectum over here on this side, rectal diameter is normal. And when there's a constipation, the rectum gets dilated. It loses the potency of perception of passing the stool. The pressure gradients are not maintained. It gets accumulated, and with there is a hard stool. And what happens? Now a long time. It takes long time when you treat these patients. It takes a long time for dilated rectum to become normal rectum. So reversal of the process takes a very long time. Therefore, the therapy has to be long, prolonged. This is what you have to explain to the parent, that your child will take time. It is not a simple 2-week therapy or 3-week therapy that is going to make difference in chronic constipation. Then what is our target? As a pediatrician sitting in the OPD in the hospital, what is your target? Your target is, first target, empty the colon. Completely, whatever stool is there, it should be emptied. And following that emptying of the stool from the colon, keep it empty. That is our job. Keep it empty so that the dilated part of the colon gets normalized. Now, what will happen? So, normal size rectum has to be achieved. This is the target of constipation treatment. Empty it, keep it empty so that the dilatation of the rectum becomes normal. Now, what do? Home to disinfect. Disinfection means that you do complete clearance of the stool over a short period of time, maybe once, maybe 2-3 days, but you clear the stool from the colon. Now, what are the situations where you have to disinfect? You have to go for this process. Simply, fecal incontinence that I mentioned to you, leakage of the stool is taking place in the underwear. There's leakage. There is, you are palpating, and a big abdominal fecaloma is there on PR examination. For some reason you do. Fecal leaks, if you are palpating on the abdominal examination, that means there's a lot of stool inside. And you need to disinfect. You have to take it out, clear the colon. No fecal incontinence is wherever there's no fecal incontinence, no fecal leaks are there. There is no need of immediate one-time treatment. How to disinfect? Understand polyethylene glycol is the best as of today by all randomized controlled trials, by meta-analysis, by recommendations, is a very good drug. And this drug is actually inert. In a way, it is not absorbed from the gut. It only absorbs the water content of the stool and makes it more and pushes it out. Hospital-based can be done disinfection, which is normally the sachets which are available are small, but there are sachets available in the market which are large, which are used for colonoscopy, actually washes. And that is called, they are for 2 liters of water. And that those big sachets has got 118 milligrams of actually polyethylene glycol. So there are just, which is freely available everywhere in the country. So you have to make of that solution 25 ml per kg per hour orally, or those where there is a problem, younger child, you may give through nasogastric tube and run it slowly till the time. What is the end point? For this clearance, the end point is that the rectal effluent should be clear. Ensure hydration during time, watch for bloating, fluid overload, electrolyte imbalance. It is very, very safe. I have used in hundreds of patients and it is quite safe, but you should keep a watch on this. But nowadays, what we see with the affluent population, they may not agree with this NJ tube, they may not agree with hospitalization. You can do actually this hospital-based one in your daycare center. In your daycare, you can do it in the hospital. But many people don't agree. So there's the alternative to this, that's the home disinfection, where you give 2 grams per kg twice a day for 3 to 6 days. Again, the end point is clear rectal influence. So that is the way you can do home-based, you can do hospital-based, you can do with NG tube, you can do orally. The choice is yours. And choices of the parents, what do they want? So best is, I think, in my opinion, best is if you are highly satisfied, if you give it in the daycare, warts, and you give oral. That is a very good thing for the child. After that, you have to maintain. So I said, clear the rectum, clear the colon, that is disinfection, followed by keep it empty. How to keep it empty is, again, you can use polyethylene glycol. This is preferred agent. More than 1 year. Less than 1 year, you should not use polyethylene glycol. There the choice is lactulose or lactulol. And this is given in the dose. It's half the dose of disinfection, 1 gram per kg per day, or you can use lactulose or lactulol 1 to 2 ml per kg per day, or lactulol 1 to 3 ml per kg per day. So this is maintenance. First was disinfection. This is maintenance which has to go on. Simply you remember these two drugs are important. Rest, all is not important. Forget about the rest. Just go with these two drugs. Maintenance therapy has to go on for a long time. I will show you what is the outcome of these patients. The rescue therapy, again, I will tell you. So after maintenance therapy is given, watch at 1 month, 3 to 6 months, at 6 months, assess the recovery. So minimum you have to give for 6 months this medicine. So mother will tell you, sir, we have been giving for such a long time. No, you have to continue because you want the dilated portion of the rectum to become normal. So you have to minimum 6 months has to be given. And whenever you are trying to take it out, after 6, we give a trial of weaning. Slowly, gradually wean it off. Don't suddenly stop this medicine. So that is how you will follow up the patient on maintenance therapy. Then this is very important. The prolonged period of time it may take. And etiological spectrum, we have done a head-to-head trial of polyethylene glycol versus lactulose in our own study. What we found that not much of difference is there. But one thing, those children who are given lactulose to begin with, many of them will not be better with that, and they may require changeover to polyethylene glycol. That's why polyethylene glycol becomes the first line of treatment in these children. We have published this work in 2019. And role of counseling, most vital role is for treatment of constipation is counseling. Compliance and counseling go together. Now what does you do? Explain the problem with a diagram. As I showed you dilated rectum, how to reverse it, you have to show to the parent, how to explain the pathophysiology a little bit. You have to tell them that the treatment is prolonged. You have to correct the identified factors. You have to go for regular trial. Make them to sit in the toilet morning, evening, spend time, relax on the toilet. And if you are using the Western toilet, you should make the child to actually have a footrest so that the angle of anorectum is maintained. And unhurried time on the toilet, incentives, avoid any kind of punishment to the child. So that is a motivational thing which you have to do for the children. Now, for the parents, what will you say? I say this, that if you have given treatment for a month, 2 months, or 3 months, if you stop this treatment, what will happen? This ladder snake, that game which we play, will be back to square one. This makes them very impressed and they can understand this, that we have to give it for a prolonged period of time. And fiber-rich diet, these are the different kinds which I've mentioned. This is I made myself with the help of the dietitian, which I distribute. Mostly coated dals have to be given, green leafy vegetables have to be given, and some of the fruits which have got high fiber, those have to be administered. And the diets, the simple thing, these are the fiber-rich diets. And we should remember simple thing, decrease the milk intake. There are certain children who keep on taking only milk, a lot of milk. That has to be decreased in these children. And the fiber required, if we go by quantity, is 0.5 per kilogram, or age of the child plus 5 grams with the requirement of the fiber. You need not to quantify that. You have to just remember that high fiber diet has to be given, and these are the dietary items. Avoid fiber poor diet. And common mistake, I would just tell you, fruits. I was in the daily IAP meeting just on this Tuesday, and they were asking about the banana feed. Should we give or not? So I said that we should avoid banana. Why? The banana has, number one, the fiber content is low. And second thing, it causes actually the stimulation of the colon, short chain fatty acids, which decrease the motility. Therefore, this is the recipe which I use, unripe banana, for treatment of diarrhea. For treatment of diarrhea, and also for treatment of sometimes short bowel syndrome, where the ileostomy outputs are very high. This banana feed, unripe banana feed, is very, very effective in these children. So these are the foods which have to be avoided. Now, what is this rescue therapy? At onset, you have done maintenance and then well controlled over the months, but suddenly they will say, doctor, he has again constipated. So that is called sudden breakthrough. It can happen in 11% of these patients. 11% is a very small, but it can happen. And therefore, you give rescue therapy. What is the rescue therapy? Simply, you can give Biscodil. Biscodil is best. Use it for just 3 days, not beyond that, along with your polyethylene glycol or lactulose. So it will break in these 3 days and continue the therapy. So that these are the doses of this Biscodil or stimulant laxatives. Now, in urology practice, I was once asked by the urology conference to talk on constipation. Why? They see a lot of it. Why do they see? Because there are incontinences, urinary incontinences which take place, and they have many other neurological problems where there's incontinence associated with constipation, and will tell you that is called this elimination, dysfunctional elimination syndrome. It can occur in many other conditions. I will not go into the depth of this, but I will tell you simply one thing. If you have any child who has got urinary incontinence, always ask for history of constipation. Very important. The criteria I have already explained to you. Why? There's a bladder, urinary bladder instability because of fecolema. They are anatomically very close, pushing urinary bladder anteriorly, and that produces incontinence. Fecalomas can compress the bladder, right? And neck and inhibit bladder emptying. So that is another thing which can happen in these patients. So therefore, you should always take this history, or you get a case of urinary incontinence, history of constipation should be taken. Natural history, 85% is functional constipation, 15% is organic, 50% resolved by 1 year, 70% resolved by 2 years. There is a subset who will continue with constipation. They are where the treatment is resistant. They will persist with these problems. And in this, the approach of this persistent or treatment resistant constipation is somewhat different. Now, what is this colonic transplant? This we have been doing at our own place, and you can see here, this is the time which we take for taking anything through mouth till it is expelled from the bottom. That is called the transit time. And this is how you can see these are the radiopaque markers that are taken orally, and then we take X-ray at certain times. This is a fixed method of doing it. And normal colonic transit time, most of the pellets are out. And abnormal CTT left side. You see most of the pellets on the left side, that means the motility on this side, left side, is affected. Or there's abnormal CTT on the right, that means again, the motility on the right side is affected. So it is used in many conditions where we have resistance or problem in dealing with the constipation. Now you can see here transit studies. Now in this diagram, you'll see the radiopaque markers are distributed throughout the colon. So this is called pan-colonic inertia. So it may cause constipation, the treatment is different. Or you have pelvic outlet dysfunction, the markers are down in the pelvis. These are all our own patient slides. It is not from any book, picture, or Google series. So this is how we should look at constipation in difficult cases. Now, this is another study. This is what I was telling in the first go, what is the criteria? Assessment of stool frequency and colonic transit time in Indian children with functional constipation and healthy control. See, from this study, what we extrapolated, very nice study, stool frequency in Indian children average 7 per week in healthy children. Although the small limited number of patients for comparison purposes, from that we extrapolated. It is not like Western children where the frequency is very, very less, and therefore the criteria, which is Rome criteria, may have to be modified as per the requirements in developing countries. We see in Burma, we see in Southeast Asia, we see India, even in adults, the frequency of the stool is different. Functional constipation, 1 per week stool frequency, what we had. Indian children have shorter colonic time. They are fast. They expel the stool fast as compared to the West. So therefore, we are called Indian happy defecators. Why? We feel happy after passing the stool almost every day. And that's why the colonic incidence of colonic cancer, which is one of the causes, major concerns in the West, is not very much prevalent in India. Most Indian children with functional constipation have normal colonic transit time. See, functional constipation, despite the fact that frequency 1 per week, but their transit time may be somewhat affected, yet they respond to this treatment. 8% children with functional constipation had prolonged colonic transit time or responded to it. Therefore, there is no need to do transit time studies in functional constipation in Indian children. This is the biofeedback. Some older children may not respond to your conventional treatment where you resort to what's called the biofeedback. And in this, what we do, you can see at the screen here, you can put the balloon in the rectum and make them to squeeze. Tell them, do it, do it, do it, do it. You will be able to do it. So biofeedback mechanism, and they'll be able to pass the stool. They have to train them multiple times. This is a very good method in older children, and also see relaxing, and passing the stool. Now, subsets requiring a different evaluation. There are alarm symptoms. Any child who has developed a delay, look for thyroid profile. Constipation and growth failure, look at celiac disease, thyroid profile. Constipation and anemia, look at celiac disease, lead level. Hypercalcemia, parathyroid profile. Infants and toddlers, all a think of secondary causes, not as a functional constipation, or look at congenital megacolon, hypothyroidism, or any other reason for that. Urinary symptoms, evaluation, and etiology. So intractable if the response is not there for 3 months, they are called non-responders. And here, I just want to show you two slides. One, Hirschsprung disease, which is commonest thought to be an anatomical abnormality in children. See, here's a plain X-ray abdomen. You can see dilated colon here in these, which you will not find. The hostra are quite prominent, which you will not see in functional constipation. Secondly, you'll see a transition zone, narrowed segment like achalasia, where there are no ganglion cells. And this is proximal dilatation of the colon because of stool accumulation. This is called transition zone in Hirschsprung disease. Similar transition zone is seen here. And anorectal manometry. Normally, when you do anorectal manometry, distension in the rectum, and then the internal sphincter relaxes. That is how we can see on anorectal manometry the sphincter relaxation taking place. This is normal. This rules out Hirschsprung disease, not a possibility. And this may be actually a Hirschsprung disease. Maybe you present absence of this does not say it is a Hirschsprung disease. You have to do other biopsy and other things. So here it is absent. The internal sphincter is not contracting. So this is for all of us today. Diagnosis in the absence of red flags for functional constipation. Look for spine, look for neurological problems, look for any other systemic examination is important. Disinfection in fecal incontinence group with polyethylene glycol. I showed you home disinfection and hospital disinfection, oral or NG tube, prolonged maintenance, therapy with polyethylene glycol, quite safe, rescue therapy of 2 to 3 days with viscodil, successful outcome should be reached, withdrawal of therapy, gradual tapering off, diet, counseling, modification, toilet training, all have to be implemented in this patient. And once you relieve the constipation, whether rich or poor, whether rural or urban, they always a smile on the face. And this smile makes you also very happy. Dr. Ramesh and Dr. Ananda also. Thanks IIP Kodzi, Kerala IIP, grateful to both of you and the organizer and Dr. Ashraf and Dr. Narayanan. Thank you very much for giving me an opportunity to talk to you. I have a lot of research on this issue, but I'm talking of practical issues only to our pediatrician fellows. Thank you very much.
Thank you, Yachha sir, for that excellent illustration on the management of functional constipation, stressing the stepwise management and the basis rationale behind the drugs and therapy. Now, next 10 to 15 minutes, we will handle the chat box. There are a lot of questions in the chat box. First, the question is to Raju Shah sir.
Yeah, sure.
Oh, 1 minute, sir. I will read out from the chat box. Sir, this question is actually from Dr. Ananda Keshavan.
Okay.
Are there any specific diagnostic tool for cognitive impairment due to iron deficiency anemia other than the IQ studies?
Yeah, there are no specific tools. You have to look for two things. One is the IQ score and the history, because by the time when you are looking at the IQ score, it is already late. So the history and what was the iron deficiency anemia or iron deficiency in the child. So whether child was born low birth weight, child was born premature, and child was anemic in the first 1000 days is a very important. And what was the hemoglobin level of mother? All three things we have to ascertain. From that we can, because there are no such tools which can tell you that the effect is because of iron deficiency. It is only just tell you that IQ is low. It could be many more reasons also.
So, okay, sir. Now, your comments on liposomal iron formulation, which is being promoted nowadays.
There are all different type of salts available, but I mean, for the oral salts, it is the age-old products which are very good and they are economical and they are doing wonder. So ferrous salt, especially ferrous sulfate, may have little more side effects, but ferrous gluconate is a good salt. And now newer, that is ferrous ascorbate is also good because there is a vitamin C which will help, it will work as a promotional element, and that will help in more in absorption. The other oral ferrous salts like, iron polymaltase complex and the carbonyl iron are also good. So if you are, getting used to some product and it helps in your children, that is quite okay. One should not change. There is no need to change. And now we have realized that the method of treating with the iron is, there is no need to give even the recommended dose of 4 to 6 milligram. It is better that you give small, because the heptidine which is coming out, if you are giving a higher dose, there will be higher release of heptidine, and probably that will come in the absorption of the iron salt. And that is why the recommendation is now to giving a fractional salt, and instead of daily, you can give an even alternate day therapy, and that will help. So there are ways by which you can, take care of these children, and simple salts are quite effective. So we don't need to go for or look for a better salt for the oral iron therapy.
Sir, next question is, what is your opinion regarding the iron supplementation in autism as well as ADHD?
Well, iron supplement is needed for each and every child, actually. That's what, I tried to mention, that every child needs. So even especially those children who are having the deficiency and certain diseases like, they need more. If the child is suffering from some neurological disorder, probably they may not take proper food and probably they will need it as a supplement also. So almost all children and normal child also requires iron supplement at least 3 months in a year consecutive, so as they have the iron store. So iron supplementation is very important in all the conditions.
Sir, your comment about the iron with zinc combination.
There are some studies which had initially showed that probably zinc will inhibit, but there are now studies which have shown that even with the zinc absorption is quite okay and there should not be any issue. Probably if you are giving in the same preparation, it is okay. If you are giving separately, probably you can keep some hours gap between the two preparations. I think Dr. Yachha would be better to comment on this if there are some any other.
Yachha sir, any comments on that?
No. What Dr. Shah is saying, I'm endorsing fully. There was initially when we were recommending for diarrhea, acute diarrhea, Dr. Barnes' time, I was one of the members of that committee, small committee, and we had said that zinc should not be actually combined with the iron therapy. So, but things are changing now. You can, and maybe it is better. If you have doubt still in mind, give it separately to what Dr. Shah said. Best is that way. You'll satisfy everything.
Okay, sir. Thank you. Raju sir, next question is, even though you covered extensively on that topic, what is the best iron salt for iron deficiency anemia for prevention and therapeutic treatment of iron deficiency anemia? Which one is the best?
Best iron salt, you mean?
Which iron salt?
Yeah, iron salt, as I said, that oral preparations are, I still prefer ferrous salts, and ferrous gluconate is probably better salt, and I prefer ferrous gluconate salt, but any ferrous salt is okay. Ferric ammonia citrate is another salt which has been used, but the bioavailability of ferrous from ferric ammonia citrate will be much less. So you have to give a large quantity and probably it may come in the way and there may be some side effects. So it is better to give ferrous salt. Ferrous sulfate, some children react very badly. So probably you can select the other salts. And the ferrous ascorbate salts which are available are considered to be little better, as the ascorbate salt will have vitamin C, and we all know that vitamin C works as a promoter of the iron absorption. So that way it will be useful. Even there are studies which have shown, especially from the adult, that iron polymaltose complex are also good and the carbonate iron salts are also good. But still for pediatric age group and especially for the liquid formulation, I would prefer ferrous gluconate salt, and the absorption is much better.
Thank you, sir. All this, the gold concept is applicable to the iron salt also, I think. What is the best IV iron and how many doses to be given after IV therapy? Then which oral iron to be used for the maintenance?
Yeah, iron, initially what we got was an iron dextran complex, and that was probably highest anaphylactic reaction, and that is the reason why it was in a bad book. But then we have now iron sucrose complex, which is considered to be a good salt. And recently 2 more salts that has come of iron. One is the iron isomaltoside. That is a new preparation recently introduced, and it is used in European countries for a long, many years, and that is good. Another compound that has come is the ferric carboxymaltose, and that is also a good compound, and there are very, very less the reactions. So these 3 can be used, and the need of a iron, parenteral iron will be only to tide over a critical situation. You cannot completely, manage the iron deficiency anemia with the parenteral iron. So probably you need to give 1 or 2 doses. Tide over the situation and then switch over to the oral salt. Yes, in certain patients who are having chronic kidney disease, where the absorption or some other GI disease where absorption is an issue, there probably you may continue as a parenteral therapy and that can help. But normally 2 doses should be quite okay. And after that, probably, yes, you can go for the iron supplementation. That should help.
Sir, and next is a basic question. What are the common iron-rich foods for children?
Common iron foods that is normally is all leafy vegetables are having a good iron. The red colored type of, or colored fruits and vegetables also has a good iron store. Tomatoes have a good iron. The beet has a good iron. The date that we normally take has a good iron. So all these food items have a good iron, and almost all the grains also has a some iron store there, so that also helps. So mainly the green leafy vegetables and other vegetables has a good source, and that can help.
Sir, next question is, how long do we supplement iron? Normally, therapeutically, we give for 3 months. Any role of maintenance therapy? If yes, what is the maintenance therapy? Or
yeah,
actually,
normally, if we give the right type of the iron, and if they are taking it regularly, then by day 14 there should be a 1 gram raise of the hemoglobin. And depending upon what was the original hemoglobin, it depends on that. So minimal that we need to give for 3 months, but probably in some children, if the iron deficiency is more or the anemia is moderate to severe, probably you have to continue it for 6 months or so. And then you have to also, as you know, WHO has recommended that every year for 3 months consecutive, you give the iron supplement so as they do not develop iron deficiency and iron deficiency anemia.
Thank you, Raju sir. This is the last question to you. Can we give iron supplements to all babies from 6 months to 2 years till
yes,
maximum brain development?
Yeah, definitely. That's a good way of doing it. And if not regularly, probably yes, give for 3 months. Then you may take a break for 6 months or 9 months, and then again give for 3 months, something like that. The first 1 year, I would like to give continuously. Then for the second year, yes, 3 to 6 months. But if you are giving a low dose, then you can continue it for up to 2 years of life. There should not be any issue.
Thank you, Raju sir. Now, next question is to Yachha sir. What is your comment about the age of toilet training, sir?
2 years plus.
2 years.
One person, one place, one voice should be, the trainer should be one. And one place and one voice. Whatever word you are using, all of you should use the same word. If family members are different, same word for toilet training after 2 years. Some people say, if you look at Nelson's textbook, 3 years. When I was making a guideline, I was searching for this, when should we write toilet training? And the consensus was that 2 years plus. That is the best time, because they cannot understand properly before that. To the cognitive sense is not so much to understand how you should pass it. Okay.
Thank you, sir. Next question is, you discussed about the PEG, role of the PEG in the functional constipation above the age of 1 year. Which one do you prefer, PEG 4000 or PEG 3000?
No difference in the two. Whether you use one or the other, they have the same effect. There's no difference. No difference.
Next question is,
secondly, with electrolyte or without electrolyte, it will not make any difference. You can use any one you choose, but your dosage should be correct.
Okay, sir. Thank you. Sir, any role of fruits, sprouts, and honey in the management of functional constipation?
No, fruits, anything that has got high fiber should be encouraged. That I showed you the table, high fiber diets. What are those? Honey will not make much difference, because honey is rich in fructose. Fructose may increase a little bit of osmolality, but not to that extent. The osmolality you are otherwise increasing by using polyethylene glycol. So honey, I don't think it should be actually educated for usage for treatment of constipation. Yes,
sir. We have a concern in our routine private practice. We rarely get a child with fecal matter loaded in colon or impaction.
No, impaction I meant whenever there is leakage in the underwear, you should ask this either the child or the parents, is there a leakage in the underwear or not? Without having urge of passing the stools, is there a leakage or not? That is called the impaction. If you don't get impaction, it's good, because my experience is in a hospital-based practice, whereas your experience is at the community level, at secondary level. So there may be a difference in that. You may not get, if you don't get impaction, doesn't matter. You treat the constipation otherwise.
There are a lot of greetings in the chat box to both to Raju sir as well as the Yachha sir. But there is a special message from one of the friends, Dr. K.R. Anthony from Ernakulam to Yachha sir. Hi, Dr. Yachha from Kochi, your old friend from UNICEF Lucknow. Hearing your talk after a long time, remember our campaign on community level detection of chalk-colored stool and neonatal biliary atresia correction.
I have created now, I have created for our country and for rest of the world as to which is called neonatal cholestasis card. Neonatal cholestasis, all over the world they have created for the stool. But recently I have published, it is going to be it is already in the press. It will come out shortly in a month or so, for the urine as well, and for the usage for the parents to recognize and see at a very early stage, neonatal cholestasis very stage. It is very, very horrifying disorder in our country. Doctors have to take a lead.
Achha sir, next question is, papaya has lots of fibers. Is it to be avoided?
Papaya you discourage. It is a less fiber, and it should not be much encouraged. I'm not saying you should avoid. It is not contraindication that you cannot take milk or milk product, or you cannot take papaya. You can take, but they are less. And instead, I showed the slide where in the fruits are to be used, like guava is there, that was there. So that grapes are there, they can be used. Banana, please put a stop, although I know that Kerala is rich in banana, and use it for diarrhea purposes.
Banana.
Banana, I told you, I use for short bowel syndromes. Surgeons are not able to control the stool output in them. I have been using this raw banana feed for them, and it works in a wonderful way. It decreases stool output because it decreases the motility of the gut through the bacterial interaction.
Sir, what is this dietary fiber? Is it same as fibric acid used in lipid treatment?
No. Fiber is actually something which is not absorbed or digested by our tract. And whatever residue is there, it is like you are making tea and you are filtering out the tea leaves. So this is something which is not getting dissolved in that. It is neither fiber, neither digested nor absorbed. So it comes as it increases the bulk of the stool. That is the fiber. Like isabol you must have heard and seen that it increases the bulk of the stool. It does not get digested. It does not get absorbed.
Sir, you already discussed about the duration of the treatment. Still, there is a question.
It should be long. No
still
less than 6 months. But don't tell the parent that it is going to be for 2 years. Initially, you tell them for 6 months. Otherwise, they will not let you treat their child. They'll say, we don't trust you. So you have to tell them, number one, the drug which we are going to use for a longer period of time is safe. It is not absorbed by the gut. It is not a habit producing medicine. It is mandated to have reduction in the rectal diameter. That is how your child is going to improve. This is what you have to tell them in practice.
Okay, sir. Regarding the PEG maintenance, PEG maintenance, whether it is twice daily or
no, you can do it once only because the compliance. You see, the children are already hard pressed. These days we have COVID and they are not going to school. But once they are in the school, it's very, very tough for them. So we are doing it, giving it only once a day. That may be at bedtime, or maybe between 6 and 8. And wherever you find the stools, or it depends upon your permutation combination. Sometimes the stool is not passed despite that. You may divide into two parts, morning and evening. Another thing which I will tell my fellow pediatricians, that it is not a fixed dose of lactulose or polyethylene glycol. What you should say to the mother or father, that you titrate the requirement of the drug. Suppose you have fixed baseline 1 gram per kg body weight and you are giving that 17 grams. You tell her, what is our objective? Our objective that the child should pass stool every day. It should not be hard. It should not be watery loose. And therefore, you can increase or decrease the dose. Suppose it's loose watery, then you tell her that decrease this dose. This can be decreased to lesser amount, and you can do it on your own. Or if it is not, he's not passing with 1 gram per kg, you can increase it to 1.5 grams per kg. So that can be explained to the mother. They can be themselves. Each time the patient cannot come to the doctor. It's very difficult. And therefore, you can just explain to them that they increase or decrease the dose as per the requirement.
Sir, you said about the age of toilet training.
Yes.
Which toilet you prefer, whether it is an Indian toilet or a commercially marketed potty?
That's okay. But for that is okay. That's okay. That's fine. But for slightly older children, what you are making, you have to sit on the toilet in constipation. So most of the people are using now Western toilets, and some are using Indian toilets. Indian toilet is good, perfect. Western toilet, you should give the footrest. Our dear friend, Dr. Shankarna Nanan from Chennai, he emphasizes on this fact that you should give a footrest to these children. And it is correct, absolutely. I also found this very useful, because you want angulation of the rectum and the anus to straighten, and the expulsion of the stool becomes easy. So footrest becomes very important, as you are using for bathing. If you are sitting in the washroom, you are bathing, you can have that kind of footrest for the Western toilet under the feet of the child.
Sir, this is the last question. Yes. Role of glycerin suppositories in functional constipation.
See, glycerin suppository is used for children who are less than a year or two in age. Glycerin, because you should not use Dalcolex suppository or Dalcolex tablet, you should not use under 1 year of age. In fact, under 2 years of age, we should not use this, right? For if you want a rectal suppository, which is for acute constipation, that is less than 4 weeks time. Many children come just 3 days, 4 days, 5 days, 1 week constipation. That is not chronic constipation. There you can use glycerin suppository. And the disadvantage of these suppositories is that it will only act locally, not over the whole of the colon. It cannot go to the rectum fully. It will only be working at the anal level or just distal end of the rectum. So you can use glycerin suppository. There's no problem with that. In all age groups.
Thank you, Yachha sir. One last question to Raju Shah sir. What is your approach in iron refractory iron deficiency anemia? What may be the causes?
In iron refractory iron deficiency anemia, we have to look for why there is a refractory, why these children are refractory. So if there is a issue, we have to take care of those issues. Sometimes, you know, one has to look for the compliance. Most of the children, compliance is the biggest issue. When iron salts are to be given, some of them, they go for constipation. Some of them may have passing stool 3 or 4 times, and so mothers are worried and they may not give regularly. So compliance is a very, very important. Then second important thing is you have to look at how they are giving. You know, sometimes they are giving just after milk, or sometimes they are giving immediately after food. Then also the absorption may not be there because there are some prohibitive factors working over there. So take care of those things. And if you have taken care of all those things and still child is not, you know, responding to the iron therapy, then you have to look for some chronic infection or some other issue over there. We all know that sometimes even end-stage renal disease is not recognized, even though child is suffering for long. And when you test them, they will realize. So whether such disease is there or not, that you have to look for. And then in spite of all those, if it is not there, you have to go for a battery of investigations and try to find out what is the cause of a refractory. And still it is refractory, then you have to go for parenteral ion therapy, and that should help, because it is the refractory means absorption is an issue. And so if you give parenteral ion, they will respond. So that is how you can take care.
Thank you, Raju Shah sir. Thank you, Surendra sir, for being with us at Calicut through the virtual world today, and for enlightening us various practical aspects of the two common childhood problems, iron deficiency anemia, as well as the functional constipation. Now I invite Dynamic Secretary of IAP Kozhikode, Dr. Nihas Naha, for a vote of thanks. Nihas, unmute yourself. Nihas, any technical issue?
Yeah, so it's all right.
Yeah.
We are
now it is okay. Now it's okay. Yes, it is okay, sir.
Right.
I was not able to unmute that. Sorry.
Okay.
Okay. Thank you, sir. Thank you, Surendra sir and Raju sir, for being with us today for such two nice topics, which is very important for all the pediatricians, and enlightening us on that such topics. Thank you for being us with today. We just heard two doyens speaking in IAP Calicut. Thank you, both of you, and for your time and such a nice, wonderful presentation today. I also thank Ramesh Kumar sir, our dear sir, who actually give us the opportunity to hear you two people here. Thank you, Ramesh sir, Andhra Yachha sir, our state office bearers, Narayan sir and Bala sir, and all other seniors in IAP and who have joined us today. Thank you all for being here today. And we'll be continuing our sessions every Friday. And whoever is free, please log in with the same ID and password on every Friday. Thank you. Thank you all.
Thank you, sir.
Thank you, sir.
Thank you so much.
God bless you all. God bless you all.
And best wishes to Ramesh Kumar.
Okay, sir. Thank you, sir. Thank you for that step.
Thank you, sir. Thank you very much. Thanks a lot.
Bye.
Now, Nihas, you can end the meeting.
Oh, yes. You can leave.
Ranjit.
Okay, bye.